Hello, I'm John Vargo, Associate Editor of GIE, and I'm also the Chief of Endoscopy at the Cleveland Clinic Foundation. Today we have with us Dr. Aaron Small. Dr. Small is a second-year resident in internal medicine at New York Presbyterian Weill College of Medicine. Dr. Small's study, done in concert with Dr. Todd Barron and others, is entitled Endoscopic Placement of Self-Expandable Metal Stents for Malignant Colonic Obstruction, Long-Term Outcomes and Complication Factors. Aaron, thanks so much for coming today.
Thank you for having me.
Why don't you tell us a little bit about your study?
Sure. We looked at colonic self-expandable metal stents over the last 9 years and our experience in placing them both for palliative intent and preoperative intent. Preoperative intent with the idea of changing an emergent surgery into an elective one. And over those 9 years, we found that we've had a great deal of success, but it wasn't without complications. And we evaluated both the outcomes in terms of technical and clinical success and risk factors involving the incidence of complications.
What were some of the complications that you looked at in your study?
So some of the major complications that can occur are perforation, migration, reocclusion or reobstruction, which involves in-stent growth or collapsing of the stent. And those are the major complications. Minor complications include things like bleeding, which is often self-resolving, and tenesmus.
So you looked at two different groups. You looked at the bridge to surgery group as well as a long-term palliation group. What were the risk factors for stent complications in both of those groups?
Sure. So when we selected risk factors, this was often based on expert opinion, things that would be most suspicious for causing complication. Some of the risk factors included complete obstruction, meaning inability to pass any kind of stool, also referred to as total occlusion. Stent diameter, we found that stents less than 20 millimeters in mid-diameter, was at an increased risk of complication. In addition, we compared non-ERCP placement versus ERCP endoscopist placement of these stents and found that there was an increased risk when placed by non-ERCP physicians. Other complications we looked at were comparing male and female gender, age, and use of Avastin, which is a chemotherapy suggested for stage 4 colorectal cancer.
What were your overall success rates, initial success rates at putting in the stents in both the palliation group and your bridge to surgery group?
Right, they were quite high. So in the goal of palliation for stent placement is ideally you want these stents to remain patent up until the time of expiration, knowing that these are very ill terminal patients. The success rate in clinical success, we had 77% of the stents remain patent within 6 months after placement, and up to 80% remained open up until death. As far as preoperative intent or the preoperative group, we achieved an elective colectomy in up to 94% of these patients. So success with a median in situ time of up to 25 days. So overall, clinical success was greater than 90%.
So that bridge to surgery was about a month?
Correct.
Okay, okay. I was interested, you know, one of the things that struck me in the paper was that the stent, the risk factor with the mid-stent diameter. Can you tell us a little bit more about that?
Sure, and it's tough to extrapolate a whole lot of information from that, primarily because the stent type, which was 22 millimeters, was often the enteral wall stent. And in a previous study, we showed that when comparing enteral wall stents and ultraflex stents, there was a discrepancy in terms of complication rate. Mm-hmm. And the enteral wall stent often has a higher degree of complication rates. It might be due to the sharp edges at the end of the stent, the fact that the ultraflex has a wider diameter, so it's less prone to get occluded, as well as the fact that it was designed for the colon.
So it may not be necessarily the diameter stent, but it may be some other design features that could be causing some of the complications.
Correct.
That you saw.
It was a univariate analysis. There were multiple factors that could have caused that.
Now the other thing that you brought up was pancreaticobiliary, or I assume therapeutic endoscopists putting these stents in as compared to those who may not have a pancreaticobiliary background. What was this experience of those non-pancreaticobiliary endoscopists? Did they have an extensive experience with intraoral stents as compared to those pancreaticobiliary, or is it just because the pancreaticobiliary endoscopists put in these metallic stents in bile ducts and pancreatic ducts, and they just gave them some added expertise? What's your thoughts on that?
I think the latter is true. I think pancreaticobiliary endoscopists have a greater degree of experience with stent placement in general, with the type of materials used in terms of in terms of stent placement over strictures, in terms of fluoroscopy and experience with that. So I think just the overall difficulty with placing pancreaticobiliary stents contributes to their expertise in placing stents in the colon.
One other question, it wasn't looked at in your study, but I just wanted to see if you had some thoughts on it, is trainee involvement with metallic stent placement. Was that looked at or thought about in your analysis?
Right. It wasn't, we didn't look at how many trainees placed these stents, primarily because they're done by people who have more experience. That's certainly something to look at in future study as to how many stents would one feel comfortable enough doing before developing an expertise and a lower risk of complication.
Well, that's excellent, Aaron. I want to really thank you for putting together a well-crafted study. It's certainly one of the largest ones in the literature, and I think it really gives us a lot of information on some of the risk factors that are associated with enteral stents. And I want to thank you very much for taking the time to talk to us today.
Thank you for having me. Thank you.
Thanks.